Welcome, everyone. I'm Lori Taylor. I'm Director of Marketing with myMatrixx. I'd like to welcome you to the webinar, Opioids in the Treatment of Injured Workers, When and How to Maximize Effectiveness. So I'd like to get started and introduce the panelists. We have Phil Walls, who's the Chief Clinical and Compliance Officer with myMatrixx. For those of you who are not familiar with myMatrixx, we're a full-service pharmacy and ancillary benefit management company focused solely on workers' compensation. Phil oversees all aspects of the clinical program. He's a clinical pharmacist with over 25 years of experience and was the recipient of the 2011 Dorland Health People Award in the pharmacist category. Second, I'd like to introduce Brian Downs, Vice President of Quality and Provider Relations with Workers' Compensation Trust. The Trust is a comprehensive workers' comp program in Connecticut serving over 400 employers representing over 50,000 employees in the healthcare sector. Brian's been with the Trust 8 years and oversees the claims, utilization review, provider relations, and payment functions of the organization. He has over 20 years of experience in the workers' compensation insurance industry in both the private and healthcare sectors. So now I'm going to go ahead and turn things over to Phil so we can get started with today's program.
Thank you, Laura. Our agenda today, we're going to spend a little bit of time talking about disability and the workers' compensation market. We're going to talk specifically about when opioids should be prescribed, discuss certain red flags that may come up in therapy and how to identify those. We will be discussing best practice guidelines and something called morphine equivalent dosage. We'll be looking at best practices as well as risk reduction strategies. And then possibly most important of all, when to stop treatment. Just to keep things in perspective, anytime I'm talking about medicine, nursing, pharmacy, I always call on a quotation from Voltaire, who said, "Doctors pour drugs of which they know little, for diseases of which we know less, into patients of which we know nothing." That was said centuries ago, and it's still a very true statement regarding the practice of medicine today, unfortunately. Also, a quote from a gentleman named Kenneth Curtis, who stated that prolonged disability is best understood as an illness that exists independently of the initiating disease. And that's a very important definition to keep in mind as we go through things today. You know, when we look at disability, about 50% of injured workers that do not return to work within 6 months are never going to work again. And it only gets worse with time. In fact, Brian, tell us a little bit about disability and workers' compensation.
Okay. Disability, you know, add the opioid dynamic to these bleak figures on disability in general, and no doubt you have a recipe for disaster. Our book of business here at the Trust revolves around a lot of patient handling activities, as you can imagine. We service the healthcare industry, and musculoskeletal pain associated with sprains and strains is our #1 injury type, claim type. And unfortunately, and all too often, we're finding that providers are jumping right onto the opioid pathway first versus a more conservative and, in my opinion, a more reasonable and safe approach, which has really lent itself to being really a big, big problem here. Next slide. You know, what we're seeing here and also across the country, about 20% of all doctor visits in 2000 included a prescription for an opioid medication. 56% of patients who received an opioid prescription had filled one within the previous 30 days. And from 1991 to 2009, prescriptions for opioid analgesics increased almost threefold to over 200 million. Overdoses attributed to prescription painkillers killed nearly 15,000 people in the U.S. in 2008, more than 3 times as many as in 1999. You know, another staggering statistic that I've come across in my research is that the United States makes only about 4.6% of the world population, but consumes about 80% of all opioid production in the world, and 99% of the world's hydrocodone, the opiate that is is in Vicodin. Whether it's a comp claim or just kind of the national debate that we're having on the delivery of healthcare in our country as a whole, we have to start asking the question, why? Why is this occurring? This graph that Phil put up has been pretty well publicized in a number of federal reports and trade journals throughout our industry. In fact, I personally thought this slide was so powerful when I saw it that I shared it with my claim staff, and in last November I presented it at our annual board retreat to our board of directors. I mean, it seems like the dirty little secret that nobody wants to talk about out there in the current process of dispensing opioids is there's no real controls in place, especially in the comp market here. And the collateral damage of that is we're seeing dependence and addiction, inability to work or engage in daily life activities, high rates of depression, and even, yes, death, as we see in this graph. Next slide, please. Temporary disability payments are 3 to 5 times higher when opioids are prescribed. I mean, that's no surprise. Study found in 17 states that many physicians who prescribe narcotics for injured workers were not even using recommended tools to monitor use, abuse, and diversion. National associations such as ACOM and others have come out somewhat publicly here with their statements that the abuse of prescription opioids has become a grave personal risk to injured workers, a disruptive force in their lives of those close to the claimants harmed by the abuse, and a cost concern to other stakeholders in the United States workers' comp system. I mean, with well-respected industry sources now reporting that prescription drug spend is approximately 19% of the total medical spend of a claim, and that approximately 25% of that spend is associated with opioid use, it's critical from a claims and managed care organization, I believe, to have a well-thought-out and strategic plan to address opioid use. If we really want to address this issue, the industry, I believe, as a whole, needs to stop talking about it as it's on every national, regional, local conference agenda. There's a lot of discussion about it, but quite frankly, I'm still not seeing a lot of movement on a national level. We really do need to stop talking about it as stewards of the industry and start doing something very aggressive about it through the use of early flags, triggers, and tools to identify potential problems early on in the life of a claim and do something about it to change the course and avert disaster. Phil, I believe the next couple of slides you're going to talk about some of those solutions we can use in our industry.
You're absolutely right. And Brian, it's interesting, if we were to go back even a couple of decades, we did not see the problem that we do today with the overprescribing of opioids. In fact, most physicians were very cautious to prescribe opioids, and as a result, there were instances of patients being undertreated for pain. Because of that, there was a sea change in the prescribing of these drugs. Physicians recognized that pain needed to be managed effectively, and they were prescribing more and more opioids. Now that pendulum has swung way too far, and as you stated earlier, we consume 80% of the world's supply of opioids, even though we only represent 4% of the world's population. So what are the appropriate guidelines? First of all, when prescribing opioids, the dependence on pain as a measure can be misleading. The real guide for dosing opioids and choosing to use them or not is the patient's level of functionality. Second, opioids rarely, and this is probably one instance where I can use the word never, never should be the only part of a treatment plan. Relying on opioids alone will always fail. There definitely need to be other components to the patient's therapy. And at that initial visit, certain questions should be asked, whether it's by the physician or others. First of all, are there reasonable alternatives? And this does not necessarily mean drug alternatives. Physical therapy certainly should be a part of the patient's management. Second obvious question, have those alternatives been tried? And if not, why? And then again, looking at functionality, the question is the patient likely to improve? If the answer is no, opioid therapy is not going to be successful. The physician should also utilize common screening tools. There are a few examples on the screen, and at the end of today's session, I believe all the attendees will be receiving a copy of our white paper. There is access to these screening tools in that white paper if you want further detail. The first one is called the Opioid Risk Tool, acronym ORT. I'm pointing that one out specifically because that is going to come up a little bit later on in our presentation. And assuming the physician follows all of the appropriate guidelines in initiating therapy, there are still points in time that you need to be aware of and identify certain red flags indicating that therapy is not going the way it should. The first, little or no relief from pain during the acute phase. If the opioid is not working or the patient's subjective analysis of his or her own pain is that it's not working, that's a red flag. If the opioid is being used for a diagnosis that we know does not have good success with opioids, then the opioid should be avoided. Examples are pain that cannot be identified or pain where there is no apparent physical cause. If that link cannot be made, then opioids should be avoided. A very big red flag is the patient, his or herself, requesting opioid therapy, and any inconsistencies that are presented during taking of the history and the initial exam, any inconsistencies in behavior, all of that should be red flags, and opioids should not be started in that patient. And in general, just any inappropriate use of opioids within the first 30 days of therapy automatically is a red flag for that particular patient. Now, many states are adopting or promoting best prescribing practices. I think Washington has definitely led the way in strict guidelines that include dosing thresholds. They also promote the use of screening and monitoring tools such as urine drug screening. Texas has recently released their closed formulary, which restricts the use of certain drugs, not just opioids, but quite a few, unless the physician obtains prior authorization. Where Texas is currently, these restrictions are in place for all new injuries that have occurred since September 1st of last year. They are going through a 2-year period where claims that occurred prior to September 1st are not affected by the closed formulary yet. However, in September of 2013, it will apply to all injuries in Texas except for a very small category of cases they refer to as old law claims. California, they have very specific prescribing limits for doctors in a state network. So many states have been adopting different guidelines, and Ryan, I believe there's been some activity in this regard in Connecticut recently.
Yeah, thanks, Phil. Yeah, here in Connecticut, a couple of recent events have occurred with the State Work Comp Commission where, quite frankly, there may be a ray of hope on the horizon with prescribing practices and use of opioid management guidelines. I think at this point, among the commissioners having these injured workers come into these informal hearings and such, they've just reached their high water mark with these folks coming in all zoned out and on narcotics and kind of seeing the true collateral damage associated with this. The first issue is that of internal dispensing. In Connecticut, the law allows providers to dispense. I mean, this really hurts us, my organization, claims folks, in that we can't track medication use in a real-time environment as we're able to do using our PBM online platform. But recently the Commission did recognize the significant cost increases with internal dispensing and repackaging and has verbally committed to tightening up the definition of average wholesale price using the original NDC number. It's my understanding that this will be coming out in our new fee schedule release sometime in mid-summer of 2012. And we're hoping that by taking some of the cork out of the bat here with the extra revenue dollars associated with internal dispensing, providers will get to a point where they're not so inclined to deal with this aspect of the visit and just give the patient a script so they can access it through a retail pharmacy and ultimately through our PBM program. The second initiative I hear they are working on is actually providing some written guidance for the providers on the use of opioids in workers' comp claims and best practice guidance. Although not published yet for public viewing, sources who have worked on this that I've spoken to tell me that the guidelines are based on the same well thought out, documented best practices similar to those recommended by national societies such as ACOM and with some other progressive work comp programs seen throughout the country. And quite frankly, I'm keeping my fingers crossed that they are released soon and not shelved. But we're hoping there is some brighter days ahead of us in terms of the management aspect and having some true guidelines that we can then go back to the providers who become outliers and kind of advise them and instruct them of these guidelines. Bill?
Very good, Brian. Thank you very much for that. And it's very interesting that you brought up physician dispensing because embedded within some of the guidelines is reference to a tool known as a morphine equivalent dose, or an MED. The MED is a way of comparing different opioids and combining the daily dose of different opioids to come up with a factor that allows us to compare therapy between one patient and another. It's also a tool that's used when converting a patient from one opioid to another. But for today's discussion, we're going to use it for comparison. The significance of physician dispensing is in order to calculate an accurate MED, we must know the patient's total daily dose. So we certainly have data from pharmacies through a PBM. The physician data may or may not be available in the PBM data. One area there that we can talk about is the existence of different state prescription drug monitoring programs, also known as PDMP. Currently, every state in the country, with the exception of 3, has a PDMP in place. Accessing that data is available in most states to law enforcement, physicians, and pharmacists. So by having pharmacist license in a state, it is possible to see what dispensing is going on other than through the PBM. With that said, take all the different sources of opioids, combine them, convert them into a morphine equivalent, and total that dose up. What we're seeing is that when a patient is approaching 120 MED, that patient is at significant risk of overdose. In fact, one study showed that when the patient is receiving 100 milligrams or more per day, they have a 9-fold increase in overdose risk. And of those overdoses, 12% were fatal. The National Council of Self-Insurers has looked at the 120 milligram threshold, which we are using today. Again, seeing that there's a dramatic link between injured workers' deaths and the rise in opioid prescribing. As you do your own research regarding MED, you're going to see numbers of 90, 100, 120, 200. I wouldn't get too hung up on which number is used, as long as you know that the higher the dose of opioids, the greater the patient's risk. Looking at some examples, what we would see is that risk, as the MED goes up, the risk rises just as dramatically. And in this case, showing a 9-fold increase as the patients hit a daily dose of 100 milligrams. Looking at actual specific patients, just to put this in perspective, the first example we have here, as you'll see by the rating over on the right-hand side, is designated as medium risk. However, for the record, any patient taking opioids is at risk, and the physician in each instance has to evaluate to determine that the benefits outweigh that risk. So I don't want to imply that there is situations where that risk isn't present. It is always present with the use of opioids. Looking at it, though, on a scale of where it goes from moderate to more severe, this first example, we're looking at a patient that's taking a combination of hydrocodone with acetaminophen, generic Vicodin, along with OxyContin. If we take hydrocodone and convert that into an equivalent dose of morphine, 30 milligrams of hydrocodone is approximately equal to 30 milligrams of morphine. They're fairly similar in terms of potency. With the OxyContin, the active ingredient, of course, being oxycodone, 20 milligrams a day of OxyContin is equal to about 30 milligrams a day of morphine. So in this particular example, the OxyContin and the generic Vicodin are both contributing about the same amount to the daily MED, about 25% of that threshold, for a total MED of 60 milligrams per day. So this is not an uncommon case. I'm sure you see patients like this all the time. Keep in mind, patients still at risk. The next example, looking at two patients, one at moderate risk and one at high risk. In these situations, we're starting to exceed that daily threshold of 120. In the top example, again, the patient is on a generic version of Vicodin, this one containing 7.5 milligrams of hydrocodone per tablet, total daily dose of 15 milligrams, along with methadone. Now, methadone is significantly more potent than morphine, and it also has a tendency to stay in the body for a significantly longer period of time. And on a patient that is taking methadone chronically, as this patient has been, 30 milligrams of methadone are equivalent to 112 milligrams of morphine. So with the methadone alone, this patient is already pretty much at the threshold that we're talking about, and combined, it puts the patient over the threshold for a total of 127.5. The last example is a more severe case, but unfortunately we do see these. This patient is on a combination of Exalgo, which is a brand name of hydromorphone, being combined with an extended release morphine tablet. The Exalgo, 48 milligrams a day, contributes 192 MEDs. So with that drug alone, the patient is already exceeding the threshold. When the morphine is added in at an additional 800 milligrams per day, we now have a patient whose MED is 992 milligrams, or 826% of the 120 milligram threshold. So definitely a high-risk situation. This patient's, without a doubt, at risk for overdose, and as we said earlier, of those overdose cases, a significant number are fatal. So knowing this, what do we do with best practices? It's one thing to identify the problems. How do we turn this into something that's actionable? First of all, from the physician standpoint, it has to start with a full medical history and physical examination. There are many things that a physician can do during that examination, including an assessment of a person's addictive tendencies. And this can be done just through simple questioning, such as whether or not a patient drinks, whether or not they smoke, whether or not they gamble. Insight into a patient's behavior can definitely let a physician know if they are a reasonable candidate for opioid therapy. Next, often overlooked, is determine the lowest effective dose. And how are we going to know the lowest effective dose? By starting off with a low dose and gradually increasing. If we start with a high dose, it's too late. Then you can never establish what the lowest effective dose is. Set and agree upon goals. And that is not goals between the physician and the pharmacist, between the physician and the nurse or the adjuster. Those are goals between the physician and the injured patient. And it's recommended that a pain treatment agreement, also known now as a physician-patient agreement or a PPA, and in the past was oftentimes referred to as a narcotic agreement. This is an agreement that basically spells out several things. First of all, the patient is going to be aware of the side effects of these medications. The patient should be informed day one that they are taking something that is addictive. They should be informed that it can have damaging effects on their body, including things such as hearing loss. They need to understand that based on certain parameters, if the therapy isn't working, that they will be weaned off of it. Weaning should never be a surprise to a chronic pain patient. They should understand that it's going to happen at a point in time, and they should have a good understanding of when that might be. The patient should be monitored with urine drug screening for two reasons. One, most obvious, is to make sure that they're taking the medication that they're being prescribed. Equally important, though, is whether or not they're taking illicit substances, in other words, illegal drugs. And if they are, they should understand through this patient agreement that they have enrolled in that that will be a reason for stopping their opioid therapy. And then last, and we'll discuss this in further detail later, but if the pain is not at least partially relieved, the opioid therapy should and will be discontinued. Brian, what have you seen with regard to best practices in your experience?
Well, we've taken the initiative, quite frankly, Phil. On our side, we, for the last several years now, use or request urine drug screens and require, okay, more reality-based. We strongly encourage that pain treatment agreements be employed with those physicians who are prescribing opioids. It's something here at the Trust we believe in. We've been pushing it for the last few years now, and quite frankly, we think it just makes good sense to do so. With respect to the opioid agreements or the patient pain agreements, it gives our organization a sense right up front that the provider is aware of the potential problems and issues. It also does the same for the patient, or at least I hope so. If an opioid agreement is not in place, we challenge that provider and ask, why not? It gives us an opportunity to have that frank conversation with that provider, and at the very least, it demonstrates to them that we're watching them. I mean, trust me, I've been in the business over 20 years. I deal with doctors every day. There's one thing that I've learned. Doctors don't like to be watched. Now, on the drug screen side, some providers do and some providers don't up here in Connecticut. We focus on the ones that don't, and again, ask why. Better yet, we force the issue, and for those who don't, we request one to be done specific to the drugs they're supposed to be taking, using a third party who coordinates that for us, and have had some very, very successful results. I just had a case about 2 months ago where this injured worker was all lined up for a fusion, poor candidate for a fusion for a host of reasons, but wanted to make sure that they were taking their prescribed drugs, and in doing so, the physician at least complied with that request, hoping that if he got over this hurdle, he would eventually get his fusion for this patient, and then pop positive for cocaine. Well, once we put that in front of the physician, the surgery was definitely off the table. So it's again one of those tools that we have been using and have seen some positive results by using it.
Okay, good, Brian. Thank you very much. And for the record, I do trust you. Looking at specifically at urine drug screening, going back to the ORT or the opioid risk tool, based on levels of risk determined by tools such as that, is a great way of determining when urine drug screening should be performed. Because that's probably one of the most common questions I get is how often. If the patient, based on the ORT, is at a low risk, then the urine drug screening probably should be done maybe once per year. If they're at moderate risk, then maybe 2 times a year. If they're at high risk, as seen by an MED of 120 or greater, then we need to start looking at 3 to 4 times a year. And if dealing with an injured patient that is exhibiting certain signs of aberrant behavior, which is, I'm sure all of the adjusters and the nurses in the audience, as well as the pharmacists, are familiar with those patients who are calling up end of the day on a Friday complaining that they accidentally flushed all their OxyContin down the toilet. Many of you have heard me say I've been waiting 30 years for the patient to call me up and say they accidentally flushed their vitamins down the toilet. It never happens. So it's that type of aberrant behavior that is a huge red flag. And in those patients, if they're prescribed opioids at all, the urine drug testing needs to be a very frequent occurrence. Now, we've talked about when to initiate therapy, how to monitor it. Well, what about long-term use? Does it have a place in a patient's therapy? It does, but right from the outset I want to say it should be a lot less common than what we see today. So hopefully this is something that we will see change over time. So it is not recommended. It can be done in a select population of patients, and as long as in that select population we're documenting that the patient is experiencing pain relief, they do show a better quality of life. There is functional improvement. Remember, that's the way to look at these patients, not based on pain, but on functional improvement. And a colleague of mine once recently made a statement to me that I thought was very profound. He said, we are a victim to the subjective nature of pain. And that's very true, because patients go in, the doctor asks them to rate their pain on a scale of 1 to 5 or 1 to 10. Or they're asked to maintain a pain diary, which is a useful tool. But one way of getting around the subjective nature, and many of the guidelines are recommending this, is consult the family member. Determine how they see that their family, the patient, in terms of their quality of life. And then periodically reassess the benefit to risk ratio in these patients. Remember, there are some very severe side effects with these drugs. I mentioned earlier hearing loss. That is a very real situation. The incidence of osteoporosis is much greater in long-term use. In male patients, they may experience something known as hypogonadism, which is why oftentimes these patients will need a testosterone supplement. So all these things need to be factored in, but again, long-term use, although it can be appropriate in some patients, it should not be nearly as common as it is. So how do we deal with this? So let's talk about some risk reduction strategies. We've already talked about the patient-provider agreement, but I cannot stress enough, it has to have very clearly defined objectives, and the patient has to have an expectation that is realistic. We are not going to fix these patients, unfortunately, in many cases. They may experience pain for a prolonged period of time, even the rest of their life. But they're better off knowing that than to have an expectation that the therapy or the drugs are going to offer complete freedom from pain, because it may not occur. We want to make sure that we're using certain assessments, such as the current opioid misuse measure. Again, there's a better copy of that in the white paper that we'll be sending out to you. The physician periodically should try to decrease the dose and try alternative therapies. There is a phenomenon that occurs in opioid therapy known as hyperalgesia, which means that these patients actually become more sensitive to pain, and that the dosing needs to be challenged on a periodic basis. And then, of course, as we've said, monitor compliance utilizing urine drug screening. In evaluating continued use, there is a phrase known as the 4 A's of monitoring. First is analgesia. Is it working? Is it relieving pain? Second A is activities of daily living. Are they able to return to more of a normal life, normal function? The third A is adverse side effects. Are they minimal and tolerable? If not, we need to find an alternative to the opioid. And then the last A is aberrant drug-taking behaviors. These are the red flags. We mentioned one, loss of control substances. Other is lying in order to obtain early refills. The patient taking it upon his or herself to increase their own dose. Any of these type activities definitely are a red flag. Another important factor in ongoing use is, can the patient return to work? All right, that's huge. That's the goal of this therapy. And then lastly, and this should be part of the PPA, are the prescriptions being obtained from just one provider and being dispensed by one pharmacy? Very important in the overall management. Other things that we can do, the use of a pain diary. Even though it's subjective, it still offers value, and many patients actually are able to manage their own doses better by interacting with the physician by showing them when their pain is worse or better. Ongoing urine drug screening, and then documentation of misuse. The physician, pharmacist, nurse, everyone involved in that patient's care needs to know when and how this is occurring. Now, as I said, possibly one of the most important discussions, when to stop treatment. First of all, goes back to functionality. If there's no overall improvement, discontinue the opioids. Unfortunately, all too often, we see that they are continued way past this point in time. Next, is there continuing pain with intolerable adverse effects? In other words, are these side effects becoming so severe, and especially if the patient's not experiencing relief from pain, at that point in time, there is no reason to continue the opioid. Non-adherence in the way patient takes the medication or in the manner that it's obtained. And we say here serious non-adherence. You know, all patients are going to have some lapses, situations that occur, but we're talking about the patient who is very obviously trying to obtain prescriptions from multiple sources, obtaining refills that are significantly too early on an ongoing basis, the presence of illicit drugs in their system during the urine drug screening. Any of these things are immediate sign to discontinue treatment. Evidence of diversion, whether it's from forging prescriptions, stealing someone else's medications, signs such as motor vehicle accidents that are related to the use of opioids or other drugs. All these are reasons to stop. And then violations of that PPA or patient-provider agreement. That should spell out what's expected of the patient. If they repeatedly go against that agreement, they need to know that the therapy will be discontinued. Brian, I think you've had some experience in this. If you would share that with us.
Yeah, as you know, Phil, 25 years ago, I was a cop for a short period of time right after college, and I guess you can take the uniform off of me, but the cop mindset stays with you forever. With opioids becoming more and more in demand for illicit use, more so than the traditional street drugs, you know, personally, our organization wants to make sure these patients are taking these drugs themselves and not diverting or just not taking them at all, regardless of what they do with them. Again, you know, the cop tells me that an injured worker with a weekly comp rate of, you know, $200 may be very well tempted to make 3 times that amount with the OxyContin prescription they were just handed by their comp doc. You know, I believe that the adjusters and the claims managers and the nurses out in the audience, you've all seen the medical reports where at the 3-month mark, at the 6-month mark, at the 9-month mark, you have pain that's still an 8 out of a 10 or a 10 out of a 10, still no return to work, no increased functions whatsoever. You know, we need to reach out to those providers and point out actually what's in their own medical reports and say, okay, they continue to be on these levels of narcotics or increasing levels. You still do not have any pain improvement, no pain gain, as they say. There's no, you know, level in improved function. What is your plan to start to wean these folks off of these narcotics since they are not making a difference anyway? And that's the aggressive, proactive, right attitude, I think, in our industry that we need to be taking. Bill?
That's good. Now, I've heard a rumor that all your adjusters tell the injured patients that you are a cop. So for the record, you are a former cop. Risk reduction. We've mentioned that several times today, and I just want to make the audience aware of something that the FDA is doing, and we're only going to spend just a second on this. It's probably worthy of a seminar all on its own, and it's a strategy that the FDA has developed that is referred to as REMS, R-E-M-S, REM stands for Risk Evaluation and Mitigation Strategy. And if you heard me talk as recently as 2 years ago, you probably heard me say that when it comes to abuse and misuse, the FDA doesn't have a role. It's all up to the DEA. Well, REMS has changed that. The FDA has recognized that they do have a role because this is a safety issue. The FDA is charged with safety and effectiveness, so it's definitely within their purview. And just like all government organizations, they're facing a budget crunch. So they were very smart in the way they developed REMS. They pushed it back on the pharmaceutical manufacturer. And they said for all dangerous drugs, which is not limited to just opioids, for all dangerous drugs, the manufacturer will develop a program to limit the risk associated with those drugs. With the opioids, I'm actually seeing some significant success. Not so much in the long-acting opioids as I am in the short-acting opioids, and especially a class known as immediate-release fentanyl citrate. These are drugs like Actiq and Pentora. In the last year, maybe 2 years, there have been about 4 brand-name versions of immediate-release fentanyl citrate that have hit the market that are very similar to Actiq and Pentora, and yet I would venture to say that no one in the audience has seen any of these drugs. A couple of brand names, Onsolus, Abstral, and you're not going to see these in workers' comp because REMS has made sure that the distribution of these drugs is restricted to qualified physicians, a limited number of pharmacies, and is only dispensed to patients that are registered on a database indicating that they have a diagnosis of cancer pain. So REMS can work. Unfortunately, it did not start until after Actiq and Pentora had already hit the market. But you know, through other methods, we've been able to limit the use of those drugs. And I think REMS is going to have a good impact as we go forward. As we start to summarize today's class, I think data and partnership is critical. And that partnership is between multiple parties, not just the PBMs and the payers, but the patients, physicians, nurses, everyone involved in the injured patient's care. There needs to be clinical oversight right from the beginning, access to real-time data, focus on injury state management. And I say it that way because on the group healthcare side, we hear so much about disease state management. And that has very little application in the area of workers' compensation. We are dealing with injury state management. And physicians need to understand the significance of that. And it's not just about pain. It's about functionality. Specifically when it comes to opioids, we should be constantly assessing the appropriateness of therapy, identifying the patients that have poor chances of return to work, and getting them off of opioids as quickly as possible, and certainly identifying those cases that definitely have a potential for misuse or even abuse of these medications. Significant part of this is predicting these patterns and then developing a method of alerting the physician or any other caregiver involved. That requires, obviously, communication with the physician. It means developing some very patient-specific recommendations. Unfortunately, when we see these cases that have gone so wrong, there's no magic cure. There's no single answer. They have to be dealt with one patient at a time. There has to be personal contact between the different parties. One avenue that has proven very beneficial is something we call a drug regimen review, which is a way that a pharmacist can take a much more detailed look at a patient's therapy than what goes on at the time of dispensing. It is a retrospective look. It is specific to individual patients. It provides very detailed information and guidance in how to manage a patient's therapy and even make changes in therapy. And when weaning is indicated, it goes so far as to give a very detailed weaning schedule. Brian, perhaps you could tell us a little bit about your experience with this.
Well, I just, you know, in 2012 here, handling claims, the complexities of them, I totally agree. This is really where you need to have a partner with a PBM and be fully integrated to help get this data that's out there, the massive amounts of data, track it, analyze it, and most importantly, act upon it in an early fashion. You know, my organization, this organization, 8 years ago had what I would refer to as a passive PBM program. Basically, some cards in a desk drawer, and when there was a catastrophic claim, an adjuster would say, okay, I think they'll be using pharma on a long-term basis, and would issue a card, stick it in the mail to the person. And when I came onto this organization, one of the first things we did was to become fully integrated with a PBM real time. And initially, the adjusters, oh my goodness, we're going to be giving the pharma away. I'm going to have so much more work to do, all this authorization and so on and so forth. And quite frankly, 8 years later, if that thing went down for a day, there would be a mutiny on our hands, because they've just become so dependent upon it. It's so critical in their overall claims analysis, and you know, as I mentioned, almost 20% of the comp pie now, comp claim pie, is pharma. I can't stress enough, it's somewhat redundant, but I truly believe, our organization believes, that we need to proactively, as a claims organization, reach out to these providers, start that dialogue early and often. Again, let them know that you're watching them and require them to follow best practice medicine. You know, again, as I mentioned, it's hard enough dealing with everything else that's coming at us with the complexities of these claims these days. I think it's imperative for an organization to have access to PharmDs to help the adjusters and the nurses interpret what's going on with the pharma side of the claim, as it's becoming more and more a critical aspect. You know, for example, I'll leave its profound financial impact on the Medicare set-asides and the ability to settle those claims. We could have a whole nother webinar on that aspect of it. And again, I'd strongly encourage the use of these drug regime reviews. I mean, our industry is very, very used to to IMEs to deal with the injury side of things, getting another opinion. That's exactly what these drug review regime reviews are. They're kind of the IME on the pharma side of things, which we have found to be very, very beneficial in trying to move a claim and trying to reduce pharma utilization, trying to get that claim to a better place to ultimately get that person back to work or settle that claim for a reasonable amount. So those are the tools in 2012. Those are the tools that are necessary to help with managing these claims. Bill?
That's good. And you use the word proactive, and I think that's very significant. The important thing about this level of management, and we focused on the use of opioids, we focused on the expense, but at the end of the day, when these medications are managed appropriately, it's the injured patient that benefits. Even though they may be a resisting party, once it's all said and done, I have had quite a few situations where the patients are actually thankful that an intervention at that level occurred. So basically, our position rests on 3 points. First, if opioid therapy is going to be initiated, identify the appropriate patients. Do that from the start, and the outcomes will be much, much better. Establish a treatment plan. So many of the guidelines recommend a treatment plan. This really should be a mandatory part of opioid therapy, and there should be a patient-provider agreement in place in every situation. And then lastly, as we said, possibly the most important point of all this is know when to stop therapy, know when to wean, and it should never come as a surprise to the patient. They should be expecting it.
Thank you, Phil. We have definitely received a lot of questions. We're running tight on time, so we're going to try to address a couple here. And again, if you have questions, continue to chat them in. We're going to compile all of these, answer them, and try to send them out after the session so we can try to get to as many as possible. One question we had, Phil, was in Texas or really in any other state, what is a pharmacist's role in reporting any questionable dispensing?
Oh, that is a very good question. I'm actually speaking next week at the National Prescription Drug Abuse Conference, and pharmacist liability is something that I'm going to be talking about. And there is increasing liability. I think for a long time, pharmacists were seen as fulfilling the order of the physician. That has changed. Pharmacists have a duty to warn, and that duty can be regarding the specific patient. It can be regarding inappropriate behavior that's seen. So there is an obligation on behalf of the pharmacist.
Okay, thank you. Another question we had was, where does the responsibility lie in terms of communicating with the patient? Does it lie with the PBM or the TPA to speak with the patient and or the doctor?
Cool. Another very good question. And I want to start at a different point than either of the ones that were referenced there. It starts with the physician and the dispensing pharmacist, because they are the ones that have the real-time interaction with the patient. Subsequent to that, then I think it's up to the PBM to utilize the data that we've been talking about, identify these trends, these red flags, and working in conjunction with the client, whether that be a TPA, carrier, whoever, and determine the appropriate intervention at the physician and patient level.
This brings up a very good...
Go ahead, Brian.
Can I just interject something from an adjustment side, a claim side? This brings up an excellent point. In our position here at the Trust and in Connecticut, there have been inquiries by our PBM to a physician, a dispensing physician, and claimant's counsel gets wind of this and cries foul and cries ex parte communication between, quote unquote, the insurer's agent, the PBM, and the physician. And we have successfully contended and defended that this is not ex parte communication. This is a patient safety issue between a physician and a pharmacist, and have prevailed in that position.
Great. Another question. I think we have time for maybe two more quick questions here. Does patient size or other variables affect the MED threshold level?
Very good question, and I think the person asking is very understanding of dosing, and although that has an effect on the prescribed dose, the calculation itself is strictly based on the different opioids that are being used and converting from one to another. However, in certain patients that require a higher dose, they're going to hit that threshold sooner, but from my understanding, the risk factor, the risk for overdose is still just as great.
Okay, and one final question that I noticed we had a few people chiming in on, going back to UDS. Is this the only test to monitor opioids? Are there any other tests available? Many folks chatted in that these tests are becoming very costly, so are there other alternatives?
I think urinary drug screening is one of the best, and this is not the first time that I've heard concerns over the cost. In fact, recently I heard urinary drug screening described as the next physician dispensing because it's an area that can be marked up by the physician. However, do not let that discourage its use because it is an important tool. In terms of alternatives, I know of nothing that is as easy to perform as a urine drug screen.
Great. Well, I think that's going to conclude today. We're right about at 3 o'clock. I'd really like to thank our presenters, Phil Walls and Brian Downs. Thank you very much for joining us and providing your perspective. And just a few quick follow-ups. Again, everyone will be receiving an email that will contain the Q&A from today's sessions because there were a lot of questions we could not get to. Also, a copy of the white paper Phil recently published on this very topic that will have a lot of this data, as well as instructions for receiving CE credit. So again, we thank everyone for joining us, and we look forward to chatting with you next time. Thank you.